I'm a neural stem cell biologist. We've been studying neural stem cells for about the last 20 years. And 6 years ago, I moved to the University of Florida from Australia. And it was my first week there. My lab is empty. I'm sitting in my office just with my laptop writing a grant. And there's a girl knocks on my door, introduces herself, says she saw an article in the newspaper that I had moved here, or to the University of Florida, and that I studied brain cancer stem cells. And she had some nanoparticles that she wanted to use to target the brain cancer stem cells. And I look at her and I go, "How old are you?" She goes, "Well, I'm 15. And I says, "What are you doing here at the university when you're 15, and where do you get nanoparticles from?" She says, "Well, I've been working at the Nano Institute for a year, and I make my own nanoparticles." So her name is Muna Oli. She's now a senior, and she still works in my lab. But through her, I met her father. And her father is a professor at the university, and he's a card-carrying ecologist. And so I start hanging out with Madden, and we realize we actually have the same job. So me as a cancer biologist, he as an ecologist, he goes out in the field and he looks at birth rates, death rates, the health of his population. And I do the same thing in my lab. I look at the birth rates, death rates, and I look at health of tumor cells by looking at what pathways are activated. And so I start going to his house, having dinners and hanging out with his friends, and realize we have another similarity in that, his friends would be talking about Bob's paper in the Journal of Ecology, where they sent 10 volunteers out here and listened to bird chirps. And then, several hundred miles away, they sent 10 volunteers out, they listened to bird chirps, and they would interpret that the birds were migrating in a certain way. And they'd say, well, that's not true for this reason and that reason. And we do the same thing in cancer biology, as we argue about people's papers, saying that interpretation's wrong for this reason and that reason. And the reason we argue with stuff like that is because neither of us actually really understand our population. We don't really understand cancer, and the ecologists don't really understand the population that they're studying either. They don't understand all the intricacies of it. But that's where the similarities ended. And so as a cancer biologist, we in general blame our lack of detailed understanding of cancer on the poor outcomes that we get. And we say, look, give me more money, allow me to study it better, and then I'll get better outcomes, which is a very reasonable way to go. But what the ecologists have done is they've developed algorithms and processes to find ways to take a population that they don't really understand, but find ways to manage that population. So Matt and I sat down and said, why don't we just ask one simple question, is can the lessons learned in a very divergent field from oncology be used to improve outcomes in cancer patients? And as I was starting to get into the cancer stuff and read the literature a little bit, we had 4 observations. And so the first observation is this data here. And this is some data looking at death rates in the United States from 1950 to the year 2005, so over 55 years. The death rates in cancer have only changed by 5% in 55 years. Now, you look at the death rates for other diseases like heart disease and stroke, for instance, and there's been a 60 to 70% reduction in deaths per 100,000 people. In the early 1970s, Nixon signed the Cancer Act. This was sometimes called the War on Cancer in the United States. Since that time, the United States has spent over $90 billion on cancer research. Now, this is not talking the rest of the planet, all the biotech companies and pharmaceutical companies. And what we have to show for that is overall a 5% reduction in deaths per 100,000 people. Now, it's not to say that we're not making progress, because we are making progress. Things are getting better. The problem is they're just not getting better very quickly. And this is an article, or a series of articles, that came out in the early 1980s, and it looked at the contribution of chemotherapy to extending to curative and to extending lifespan. What the authors concluded here, that it was less than a 10% contribution. And they said in the paper that the majority of patients exposed to chemotherapy will get most of the benefits, but most of the side effects, but minimum of the benefits. And then a decade later, there was an Australian group that looked at the contribution of cytotoxic chemotherapies to 5-year survival. And what they ended up concluding was the contribution was about 2% in both the United States and in Australia as well. And this review article that was in Cochrane Reviews on colon cancer looked at the contribution of chemotherapy to colon cancer and found that less than 10% of the patients actually benefit from this. And what they concluded in this article, he said, was, put bluntly, over 90% of treatment is either futile or unnecessary. And now we are moving, though, away from cytotoxic therapies. There is starting to be more of a movement into having targeted therapies. There's still toxicity with it, but toxicity is less. The problem is that many of these targeted therapies are targeted for a very small subpopulation of people with that particular cancer, but that therapy is being rolled out broadly to everyone with that type of cancer as well. And then, to me, what is actually the more important question is, what do 5-year survival statistics mean? And what does this tell us about treatments? Because 5-year survival statistics are getting better. And what this article concluded was that the 5-year survival statistics are actually reflecting better and earlier diagnoses. So just consider if you had the same treatment, but you diagnosed a patient 1 year earlier, your 5-year survival statistics would be increased dramatically. Now, the treatment had nothing to do with it. It was actually the diagnoses got better. So, as a non-cancer biologist, when I look at this, and except for notable exceptions, and there are several notable exceptions, there's probably more than what I have listed here, is that the contribution of chemotherapy to cancer outcomes is actually fairly small. In the United States, cancer therapy is about a $100 billion a year business. About a quarter of that, $23 billion a year, is for chemotherapy. If you go to clinicaltrials.gov and type in chemotherapy, you get about 18,000 trials are ongoing or have been done. And you start scrolling through those. A lot of those therapies are just retaking drugs, cytotoxic drugs, and trying to reposition them. Let's take cytotoxic drug 3 and let's add it to number 10 and to number 15 and let's see if it does any better. This has been going on for decades, and this reminds me of this definition of insanity, where you're trying to do the same thing over and over again and expecting that it's just going to be a different result just because you do it again and again and again. And then the last observation really comes from my friend Madden and from the world of ecology. So the ecology world gave cytotoxic chemicals like DDT for decades to try to eliminate pest populations. And basically what they learned is that you just can't eliminate pest populations. It doesn't happen very often, and not only do you not eliminate that pest population, but you also damage the environment at the same time. So this is when we started thinking about eco-oncology, and we would like to propose that this is how oncology will be practiced in the future, and it'll basically be a marrying of what ecologists have learned and what the oncologists have learned as well. So when we talk about ecology, so one thing they learned is that eradication programs rarely ever work. There are exceptions to this rule, but they usually don't work. And one of the correlations that we can make is we can make a correlation between a cancer population and a pest population. So if I have a bunch of pests, I could have literally 1 billion pests running around in this small little, confined area. Now, a tumor is very similar. So a tumor the size of your pinky or the size of your thumb is literally composed of 1 billion cells running around in this small little confined area. So each one of those individual pests can be looked at as sort of each one of those individual tumor cells. And now, this eradication program, this is coming from the ecology world, eradication programs for pests do not work when, but each one of these statements, you can think of this in the terms of cancer. So they do not work when you have late detection. They do not work when it's heterogeneous, and so tumors like brain tumors are highly heterogeneous, very poor outcomes. Tumors like testicular cancer, much more homogeneous, has really good outcomes. When there's a high reproduction rate, so when tumors have lots of cells dividing in it, that ends up increasing the grade of that tumor and the outcomes are poor for that patient. When pests move to new locations, or when a tumor moves to a new location, when it metastasizes, outcomes are worse. And when the pest population or tumor adapts or can develop resistance. And it's just this last area that I actually want to focus on and talk about, because I think this is an area that we can actually influence to try to get better outcomes. So the ecologists, what they did in the 1960s, based on the evidence they had from trying to eliminate pest populations, is to develop a thing called insecticide resistance management. And there was a number of reasons for why this resistance occurred. And a couple of reasons that are pertinent to cancer biology is that the pest control is almost exclusively focused on single insecticides that provide a really strong selection bias. And if you take one pesticide with a strong selection bias, wait until you get resistance, and then you go on to another one, apply it until you get resistance, and then another one and another one. When you think about oncology, this is basically the modus operandi. You take a toxic drug, you use it at maximum tolerable dose, and you use it until failure, and then you go on to the next drug afterwards. So what they did is they came up with things called strategies for resistance management, and one is called management by moderation. And what you're trying to do here is that the pest, and for the oncology, the cells that are actually sensitive to treatment, you want to maintain that population because that population plays some role with keeping the resistant population at bay because they're all competing for the same resources. There's management by saturation. And this doesn't mean saturating the environment with lots of toxic compounds, but rather it means what you're trying to do is saturate the pest's ability to adapt. So if it's going to turn left, you want to be able to stop it from turning left. It's going to turn right when it's adapting, you want to stop it from turning right. And the last one is management by multiple attack. So you want to use multiple agents, but use the concentration of those agents low so that your selection pressure that you're putting on that population is low, but you need to use multiple agents to be able to do that. And ultimately the goal here is to slow down the buildup of resistance in that population. So today, there's this handbook. So if you have a pest population anywhere in the world, you pull out what is called the Integrative Pest Management Handbook. And it has a whole list of guidelines that will give you some guidance on how you want to deal with that pest. And one of the key things, though, however, is the goal of this. And the goal of this is actually not to eliminate the pest. The goal is to keep the pest at a reasonable level, and this usually has to do with economics. So my pest can eat up 20% of my fruit population, and that's okay. I can deal with that. But you don't want to try to eliminate, because when you try to eliminate it, the outcome rarely ever is good. And again, the goal here is to stop it from developing resistance. So this insecticide-resistant management and integrated pest management. So what I've learned 4 things. And the first is that it's about control, not eradication. Second, it's about focusing on administration of non-toxic compounds. It's also about intelligent use of toxic compounds. So it's not to say we should stop using toxic compounds, because there is some benefit, but we need to use them sparingly. And the last thing to me is the most important, is never ever allow resistance to develop. And so in oncology, the rule of thumb is that when a patient when it becomes resistant to one drug, the chances of them responding to the second drug is 50%. And then when you find the drug that they respond, and they develop resistance to that one, the chance of the next one, drug responding, is now reduced by another 50%. And the reason for that is both pests and tumor cells, not only do they become resistant to that drug per se, but they upregulate general resistant mechanisms which make them resistant to other compounds as well. So what we've been doing in my lab over the last 5 years is we've been trying to implement some of these concepts of ecology and also complex adaptive systems into cancer biology. One of our projects we call adaptive therapy, where we actually adapt the amount of treatment to the tumor. So when the tumor is stable or shrinks, we actually reduce the dosage, because we want to be able to reduce that selection pressure. Another one is called communication. Tumor cells communicate with each other, and it's that communication which ultimately allows them to adapt. If we mess up that communication, we can slow down that adaptation and slow down their ability to develop resistance. And the last is the one I want to talk to you about today, and it's a program that we call Death by 1,000 Cuts. So a couple of years we started brainstorming about this and what we wanted to do. And so the first thing we wanted non-toxic treatments that could be stacked and used in combination with conventional treatments. In choosing our non-toxic treatments, there needed to be a significant body of evidence that these treatments had some safety and efficacy. And the reason we wanted this is we wanted to move into clinical testing phase as quickly as possible, because our models in cancer, as a matter of fact, most of our models in biomedical science, they're informative. They tell us something about the disease, but rarely are they ever predictive of what's going to happen in a human. So the only way you know it's going to work in a human, you just have to do it in a human. And last, we wanted a practical treatment that would have high compliance. And this just isn't something that's gentle and nice for the patient to take, but this is also something economic. And so for anyone who's had a loved one that's been going through cancer treatments, you'll have some idea of the absolutely astronomical cost of some cancer therapies today. And therapies, which can cost tens of thousands of dollars every month, and with increased lifespan by weeks or months. So this got us thinking about natural products. So we did a literature search. There's about 70 natural products that have anti-cancer effects, way too many to study. So we put an inclusion-exclusion criteria together. So one of the criteria is there had to be a substantial body of evidence in the literature that they're both in vitro and in vivo that this product did something. And so we each product had to have dozens to hundreds of research papers. The second thing is that there had to be evidence of safety of the compounds at doses that are used for efficacy. And you don't always see this in the natural product literature. Third thing is what we wanted to have products that were safe. And in the United States, there's a category they have called generally recognized as safe. And if you have that status at the FDA, it's really easy to get those products into humans. We also, though, needed to get this from a reliable supplier. This was actually one of our most difficult things, to find a reliable supplier, but we also wanted a supplier that was providing this to humans and that also had human safety data on that product as well. And lastly, there had to be known mechanisms, because we knew we were going to fail along the way, and if we had some idea about mechanisms, it would allow us to make good decisions of what we were going to do next with it. And so our first thing is natural products, is we came up with 6 of them from that criteria. We did a tissue culture screen looking at all permutations, combinations, and we screened it, though, at the concentrations that we knew from the literature that we could get in the plasma of a human by oral delivery. And what we found is that each one of the products in and of itself actually did very little, but the combination of these 3 products had a really strong effect. And the 3 products are, one is a catechine from green tea called ECGC, the second is curcumin, and the third is sulforaphane. And sulforaphane, its highest concentration is in crucifix vegetables like broccoli, cabbage, Brussels sprouts. But its highest concentration is in broccoli sprouts. And you know the alfalfa sprouts you buy in the grocery store? You can get broccoli sprouts like that. If you eat one of those containers of broccoli sprouts, you get a therapeutic dose of sulforaphane. And what we actually use is we use freeze-dried broccoli sprouts, because it keeps the sulforaphane in an inactive state, so when it gets used, because it has a very short half-life. Now, the second aspect, at the same time that this project was going on, there was also a project looking at metabolism in tumors. And we got very interested in the ketogenic diet, so I won't go over the details. This group knows a lot more than I do about it. And there was a PhD student in the lab. So we also started putting everyone in the lab on the ketogenic diet. And it turns out it's really hard to do. And so a PhD student that was doing the ketogenic diet says, no one's going to do the ketogenic diet. She says, so let's do a modified ketogenic diet. Again, something you're all really familiar with. She prefers to call it a high-fat, low-carb diet. And so this is basically a Atkins-like diet, 10 to 20% carbohydrates, and supplementing with medium-chain triglycerides. And so the graduate student's name is Gina. Gina looked at 2 metrics. She looked at 2 physiological metrics of the ketogenic diet, glucose levels, ketone levels. And what she found was that her modified ketogenic diet compared to the ketogenic diet basically did the same thing. Glucose levels come down, ketone levels go up. And she found that when we took human brain tumors and put them into a mouse, is that the ketogenic diet and her modified ketogenic diet had the same effect. They both delayed the time when the animals died significantly. So this is a classic Kaplan-Meier growth curve. The modified ketogenic diet and the ketogenic diet performed identically. So now when we take this, our natural products, we call them epidifurfan, because my colleagues like to have a fancy name like that. They don't like to hear the word natural products. When we take epidifurfan and we add it together with a modified ketogenic diet, we call this Cancerna. So one of the first things we want to know is Cancerna safe? And so one of the metrics for safety that you use in rodents is just body weight. And you can see here, this is over time. The y-axis is body weight. The red is the Cancerna diet. The animals lose a little bit of weight at first, but they quickly gain that weight back. We looked at enzyme levels of organs and found that they were normal. And we did a CBC, found that that was completely normal. So based on body weight, complete blood count, liver, kidney, and pancreatic enzyme levels, the diet, the Cancerna, appeared to be safe. And so maybe a little bit about the model we use. So the model we use is we take tumor directly from surgery, we put them in tissue culture, and we grow them without serum, and we grow them in defined media using what we call the neurosphere assay. And we can propagate these lines, and we can implant the cells back into animals, either sub-Q, or we can implant them intracranially, depending on what kind of question we're answering. And we also, though, we take samples directly from surgery, and we put them directly into mouse as well, so they've actually never seen tissue culture. So again, it's another Kaplan-Meier growth curve, time on the x-axis, percent survival on the y-axis, and the epidifurfan significantly increases life expectancy of these tumor-bearing animals. I already showed you the ketogenic data. And when we combine the MKD and the epidifurfan for the Cancerna, we get a further increase in life expectancy in the animals. Doesn't cure these animals. The animals all die. The tumors do grow. They do become resistant. But there is a very significant effect that we see on increasing lifespan. Now, we never expected that this was going to be a standalone treatment, but something that we would use together with standard of care. And there's 2 standards of cares for GBM, one which Adrian will talk about next, which is radiation, and the other is a drug called telazolomide, or TMZ. So we looked at telazolomide, and what this graph is looking at on the y-axis on the x-axis is time, the y-axis is the size of the tumor. And so the red line, you can see as the tumor gets bigger as time progresses. The animals that were treated with the TMZ, the yellowish type line, is reduced. The Cancerna treated animals performed basically the same as the TMZ did, but when we combine TMZ with the Cancerna, it had a significant effect on reducing progression of that tumor. And in GBM patients, up to 50% of GBM patients are intrinsically resistant to temozolomide. In other words, the temozolomide does nothing for 50% of the patients. And virtually every patient will become resistant to temozolomide after they do their standard of care. So we wanted to know what would be the effect of Cancerna if we use this on resistant cells. So we took one of our TMZ resistant cell lines that we got from a patient post after he had done standard of care. And you can see here from the red and the green line that the TMZ-treated animals, the tumors progressed at the same rate that the control tumors progressed. But the Cancerna-treated animals had a significant reduction in tumor progression. And interestingly, when we did Cancerna together with the TMZ, there was a further reduction. So in other words, the Cancerna treatment sensitized the tumor cells to TMZ. And we have some ideas of what the mechanisms and why that may actually be happening. And here's an interesting experiment that Gina did in the lab. So she had placed the animals on the Cancerna diet for 2 months. I think this is when we were just doing some of the safety studies she was done. And she thought, I've had these animals on the diet for 2 months. I wonder what would happen if I implanted 1 million tumor cells into the hip of the animal. Now, when we do that, we get virtually 100% of the time animals develop a tumor. But in these animals that had been on the diet for 2 months, only 40% of the animals developed tumors. And then we left those animals for 6 months. We did autopsies on them, and there was no sign of tumors. It's not that the tumors were laying dormant and not coming back. They were completely gone. And in those animals that did develop tumors, their time to get to a size of about 300 millimeters cubed took them about 3 times as long to basically get to that size. So we looked at other tumors as well. We've looked at colon tumors, where again we get a significant increase in lifespan. We've looked at lung tumors, where we get the same effect. And we've looked at breast tumors as well, where again we see the same general effect. And so the question is, how is this happening? What could some of these mechanisms be? And this, I think, follows on from what Tom was talking about, his push-pulse a little bit. What we call this horizontal and vertical inhibition. And what we want to do on tumor cells is we want to target tumor cells horizontally, in other words, multiple pathways, because when you shut down one pathway in a tumor cell or in a tumor population, that population adapts and just uses other pathways. So we want to shut down more than one pathway, but we also want to target them vertically. So within a single pathway, we want to target not just one node, but multiple nodes in that pathway, because again, what tumor cells as a population are able to do, if you shut down one pathway, they just work around that pathway or go downstream of that pathway to get the effect that they want. And ultimately, because we're very interested in the metabolic aspects, is we also wanted to put that together with targeting tumors in a metabolic sense by lowering their food supply, basically, through glucose. And so this is ultimately just applying the principles of ecology that I was talking about. So it's management by multiple attack, where we're using multiple agents. It's management by saturation. So what we're trying to do by giving multiple agents is that we're trying to target the adaptation or the defense mechanisms that the tumors have. And lastly, it's management by moderation, because each one of these compounds, when we used on our own, did very little. And because the selection pressure is actually fairly low. But again, when we get that combination, we're able to get a synergistic effect of it. And so when you look in the literature, each of these agents, the ECGC, the curcumin, and the sulforaphane, target literally dozens and dozens of pathways. And then, of course, the modified ketogenic diet targeting the tumor at a metabolic avenue, but also targeting things like the mTOR pathway. So we've begun over the last couple of years to look at all kinds of things, and this is probably not the right forum to go into all of this, but this is just a summary of some of the pathways and some of the reductions that we have seen, and these are all sort of key players in many types of tumors. So this horizontal and vertical inhibition is really ultimately an extension of following some of the things in integrated pest management or insecticide resistance management. And so what we've been able to find then, by sort of, with the help of my ecology guru, Madan Oli, is that we can take some of the things that have been learned and applied in the real world for decades, and we can take it and apply it into the world of oncology and hopefully get better outcomes. So I'd like to thank the people that have been involved with this work, in particular Dr. Loke Delroy, who's an assistant professor in the Department of Neurosurgery at the University of Florida, who works within my group, has really probably been the main driver of this. Regina, a PhD student who's done all the ketogenic work. Madan Oli, who's been my ecology guru. And Dennis Steinler, another great colleague of mine who's helped out a lot. But people I want to really thank are all the undergraduates. So in the past 6 years, I've had 100 undergraduates in my lab. And there's usually about 30 at any one point in time. These are the kids who are giving up their weekends, they're quitting their part-time jobs, they're coming in the evenings, all just to help us generate the data so I can present it to you today. Thank you.